Welcome to the Dogtbros, where we have an honest discussion around vet life in and out of the clinic. My name is Brandon, and I'm your doc of the day and your guide to this episode. I'm a small animal internal medicine resident living in Ames, Iowa, and I'm here with my closest friends from vet school.
Hey, this is Adam. I am a relief veterinarian in Louisville, Kentucky.
Hey there, this is Jeff. I'm a dermatology associate veterinarian in Louisville, Kentucky as well.
Hey, this is Chris. I'm a GP in North Carolina.
All right. And on this episode, we're going to be kind of covering a topic that I think is a little undervalued, but I think it's important. For me, as a medicine resident, and I think Jeff is going to agree, our primary patient population is referrals from general practitioners. And a lot of times the question comes, when do I need to refer a patient? So that is a tricky question. It is something that varies on a case-by-case basis, on a population basis, like where you're practicing, how far away certain places are from your primary hospital, like the caseload that is present in the area can affect like the availability of specialists. In some areas, there's a drought of specialists, so to speak. So before we get into that, just kind of a quick icebreaker question like we normally do. This is really simple, but it's probably going to spark some debate. So the question is, and this is just open to everyone, college football or NFL, what's better?
College football.
See, that's where I agree.
All right. Yeah, I mean, like we're heavily biased. This is Jeff, but I mean, everybody here knows I'm a Georgia Bulldog, huge football team, extremely biased, and I'm fine with that. We got shafted on not being in the playoffs, and we literally crushed the team that we were put up against for the bowl game. So, even with 2 championships. So I'm just, I'm tired of talking about this. Pissed.
Hey, this is Chris. I think it depends on the game. Is more with it. I like both, but JT, that game was a snooze fest. Like I don't want to
snooze.
I don't want to watch Georgia just annihilate FSU.
This is Adam. I would typically say NFL. I'm more of an NFL fan overall. I really didn't give a shit about college football until I moved to Alabama. And then Alabama, you can't reside in Alabama and not be a college football fan. So I slowly became a just college football fan in general. And I'm from Kentucky. I grew up watching UK play basketball, so I like to watch UK play football. But, hanging around these guys, I learned to root for Auburn. I learned to root for Georgia. And even the Hurricanes, Chris, I'll pull for the Hurricanes too. So yeah, I've kind of shifted a little bit, I guess, over the years.
He doesn't even go there.
I didn't. My parents went there. I mean, at least I have a reason to root for them growing up, but
that's valid.
Yeah.
This is Brandon again. Yeah. For anyone that hasn't figured it out through any of the episodes, I'm a big Auburn fan, Auburn grad. And I second what Adam said. You can't really live in Alabama without paying attention to college football. But anyway, moving on to the main topic today. So I have a little quote, being I think Jeff can relate to this as well, but after going into residency, you kind of learn like, I have to be up to date on all the literature that's out there all the time. So my mindset goes to what's papers that I can find on this topic. There's actually there's some literature out there about the ethics of referral. There's a paper from back in actually 2006. There's a couple of others, but this one was really relevant. It's called The Ethics of Referral. And they had a really good quote just to kind of get you guys in the mindset of how you should think about referrals and how maybe some people think about referrals where they should be thinking maybe in another camp. There's 2 potential ideal types of referral that can be like, or ways to refer that can be considered. So one is this garage mechanic model, and then the other is like a pediatrician model. Garage mechanic, the practitioner has an obligation to the animal owner, and just like a car's mechanic would have an obligation to the car's owner. Whereas the pediatrician model is essentially the veterinarian is like a pediatrician. Their moral obligation is to the patient, so as if to a child rather than to the client. And in the big scheme of things, like we aim to like adhere towards the pediatrician model because we want to do what's best for our patients. But at the same time, our patients, are technically by law property. Last time I checked, I think anywhere nationally or maybe at the state level, there's different rules and regulations that I'm not aware of. But it's we're advocates for the patient. We're advocates for the dog or the cat that we're seeing. So kind of with that setting the table, does anyone have any sort of way in which they, approach referrals? It's not something that every general practitioner is going to have to deal with, but occasionally there's a case where like, ooh, this is out of my depth, or this is weird. So we can even go off of like previous experiences as well. I don't know if anyone can start.
This is Adam. So yeah, I'm really fortunate to live in a little bit more of a bigger city where we do have some specialists in our area to where I can refer if need be, which has really come in handy on medicine cases, on surgical cases, patients with cancers, patients with neurological conditions, things that are just kind of outside of my wheelhouse in terms of diagnostics and treatments. I really like having that as an option. Whenever those cases come up, I talk with the owner and explain to them, this is something that's a little bit more outside my wheelhouse. I would recommend referral to see a specialist. There are specialists in town. I give them the information. Some people are willing to do that, and some people aren't, or they financially can't. And in those instances, I try to work with them and just do what's best for the patient that I'm capable of doing. But anytime I get something that is a little bit more uncomfortable or something that I feel like would benefit from that, I always try to encourage them to at least consider that as an option if it's something that they feel that they can do.
This is Jeff, and I'll give a little bit of her perspective, which is interesting from the time I was in general practice and then now. Back when I was in general practice, I think the situations were exactly like Adam described, as far as like, this is what I can do, this is what's in my wheelhouse. And having that nuanced conversation with each and every client was really important. And then from now, it's interesting because there are some cases that I still do referrals to. So there was a case last week that had really high elevated liver enzymes. And I said, hey, I think you need to see an internal medicine specialist. Here's somebody that I trust to, go and consider some additional testing. That's testing that I don't do. And I also have cases for like oncology. There's some skin cancers I'll manage, but I usually will offer my clients to go see an oncologist anyway, or an internal medicine specialist in the area who deals with oncology, because that's also technically not my specialty, but there are things that I can do that I'm really comfortable with. So it's interesting because I've had kind of both sides of like being in specialty land. Sometimes I am the end of the line, which I know Brandon can probably relate to, where the client kind of expects you to fix, quote unquote, fix the problem, even if it's not something that's quote unquote fixable or curable. And then there are some cases where I still have to say, like, this still needs a doctor who's not me. And I think that's an important thing to keep in mind when you're deciding when and how to refer.
And this is Chris. I'm in the same boat as Adam there. I mean, we're kind of in a bigger-ish city, so we have specialists to refer to, but we don't have all the specialists. Luckily, we're not too far from the vet school or from Charlotte, which is a bigger city. But again, we can't always refer. And going back to kind of what Brandon was quoting, being like the mechanic or pediatrician, I feel like you kind of have to play both roles depending on what the client gives you and kind of how you're can deal with it. If they're able to go to specialty, then we'll refer them, and definitely want to refer. And if it's especially if it's out of our wheelhouse, but if they can't, I mean, we just kind of have to figure it out and call for consults if we can. I mean, I've definitely have consulted JT and Brandon about certain cases, and then I've called our local specialists about certain cases just to kind of make sure I'm going through the right thought process on how to approach a case that's like a little bit out of our wheelhouse.
Yeah, I'm glad you brought that up. This is Brandon again. For me, it's interesting. Like at Iowa State, big university specialty hospital, we have most of the departments that are available for like specialty care. We have what's called a message board where clients can call and the front desk will put messages there. But you can also, as a general practitioner, put in a consultation that will go to the message board to be evaluated by a specialist, and they can answer some pretty specific questions. You can give them blood work. You can give them some imaging. You can give them, ideally, like if you have imaging, like an imaging report from a radiologist. There's a lot of like options, like I guess in our situation where even if a referral can't occur immediately, or maybe a client can't physically refer for whatever reason, there are ways to get additional information. And that the message board has been great, because sometimes there's cases where, yes, it's complicated, but it's something that I think a general practitioner can do without my like physical input at all. And I've had a couple of cases where they've had successful management, depending on the problem. So, just out of curiosity, do you guys utilize anything like that, or do you have like maybe a closer relationship with some specialists out there than maybe people would realize?
This is Adam again. Yeah, so in those instances where some people may be hesitant to go to referral, I certainly let them know that, I'll do what I can to try to manage things. I'll dig in and do a little bit more research, or I am fortunate enough to where I do feel comfortable enough with the specialists in the area to reach out to them if I have a question. I've reached out to a couple of the internal medicine specialists here on several different occasions, just to kind of ask them some questions, and they're very receptive to that. They're very, very nice and very willing to work with us to kind of help that, because again, they have busy schedules too, and I'm sure you guys can kind of relate to this. They have busy schedules, and if it's something that I can do, they're more than willing to give me that advice. So that's one less patient they have to try and squeeze in, or maybe unfortunately have to push back several weeks because they're so busy. Whereas if they can just give me the advice and I can do it with my resources, that may be better for them as well. So kind of a symbiotic relationship with that conversation. Other options that we have is, if I recommend referral to, what comes to mind is surgery. So certain types of surgeries like medial patellar luxation surgeries or cranial cruciate ligament tears, things like that. Obviously, I recommend a specialist for those. If people kind of push back and, are worried about cost and funds, I encourage them at least to go have a consult, to at least just schedule a consult to speak with the surgeon, to know exactly what they're looking at cost-wise, recovery-wise, and the whole 9 yards. But if they are just against that, they're like, I can't do it, it's too expensive. I know there are some general practitioners in the area who aren't specialized, but they do those surgeries, and it may be a little bit more affordable to the client as well. So, again, we are recommending that specialist first. But if that's not an option, maybe finding some different sources or different resources for the client to at least have as a secondary option.
Yeah, I think that's great. Surgery is really a tricky one because that's like one of the more physical demanding things. Like sometimes, there's things surgeons will look at and maybe not require some sort of like physical intervention, but I'd say like 95% of the time they're going to have to do something especially if it's an emergency. But it is good that you have those options and have like that relationship with the specialists. I don't know. What about you, Chris?
There's a couple internal medicine specialists that we have a relationship with. I'll call them for consults. So they're pretty busy. So they're definitely willing to kind of do what Adam said. Just if we can figure it out with them on the phone, and then it kind of saves them a trip sometimes. Especially some of the ER, that kind of any emergency type things coming up, we can talk to them. They're really helpful when we get on the phone with them. And then surgeons too. You guys know I like to do more surgery. So there's times we'll consult the surgeon and text them and say, hey, this is the case got going on. And there'll be times we'll say, hey, yeah, you guys, we can do it. Or that looks like something you guys can handle. You guys definitely go ahead and do it. But we'll consult with them. And then even for some like of our procedures that we know how to do and we're comfortable doing, we'll still give the option to go to a specialist, and it's kind of up to the owner if they want to go to the specialist or not. So we're always referring, and it's just if they want to go with us, we'll do it, and if they want to go with them, we're more than happy to send them on there, send them over to the specialist and get a consult with them too. So, but yeah, we have a good relationship with all of them. It's kind of one of those things like we wish we had more in the area, and just like everyone else does, there's just not enough. Like we don't have a dermatologist in the area. The closest dermatologist is about 2 hours away. And then we don't have a cardiology is another big specialty that we don't have that's super close. So it's a lot of it's internal medicine gets hit with just about everything now because they're the only ones in the area. Yeah. We have a radiologist. So we'll send out rads, or we'll do the through the lab request. So I think that kind of helps out a lot too with radiology, because you can kind of send it to anybody and they can do that remote. So that kind of helps out with that. But locally, I mean, we just have a couple surgeons and a couple internal medicine docs, and then a couple ophthalmologists too.
I'll call him when I have to, but our dermatologist is kind of a smart ass. So,
you know what? I'm going to stop taking your calls, Adam. I've never fired a referring doctor before, but here we go.
Oh, man.
You heard it here first. Anybody else can call us. Anybody else.
All right. Well, no, those are some good points. As far as I'll kind of switch gears a little bit. As far as on the specialist side, I'll start with you, Jeff. Like, are there things that you can think of? You know, most of your things are going to be referrals from an RDVM. What kind of tools or things do you need from them to make the appointment successful? Obviously, records from that veterinarian are a big one, and for me, that's still a challenge to get all the records sometimes. But kind of including that as well as other things, like what kind of things do you generally need?
Yeah, I'll say, obviously, specifically from a dermatology side, records are great. It's really helpful. I know GP is a fast, busy type of deal, and sometimes we're like that too. Like you're not able to write page-long reports for every case. It's not reasonable. But I do think it's helpful if you have something that's really, really strange, if you have time to write a sentence about it, or at least what you've done. That's super helpful, specifically if it's typed. So this isn't shade at anybody, but handwritten records are still really common in my area. And sometimes I simply can't read it. So it's really helpful if you have time and you know you're sending something that's not like your classic, I'm sending this patient for it probably has atopy, I'm sending it for allergy testing, or I'm sending this case because I think it's autoimmune or cancerous, and we'd like you to consider looking at it for biopsies and seeing what steps are next, or some sort of genetic disease, like things that you kind of have an idea about are not so bad with really, really minimal records, because I really do read pretty much everything that comes to my desk, and I try to look at it right before I go and see the cases, and I write down the medications and I put them in my record. So when my referral letters go back, I know everybody doesn't always read them, and that's okay. But yeah, I really try to get through a record. So if you call me and have questions, I can say, oh, I see, I wrote down that you gave XYZ antibiotics and this and this and this, and try to give a good thorough plans. So if you can type something to send my way, that's super, super helpful. Even a sentence about what you think is going on, if it's something weird or unusual, is extremely helpful. People ask me a lot about, do I keep things on steroids or not? It's very nuanced because I'm the type of guy who's like, patient comfort number one comes first. It is preferred if things are off steroids before they can see me for any period of time. But I work around it. And if you're not sure, definitely give us a call, send us an email, send us a text. Like we have it. We have lots of forms of communication, but I'm always happy to, I always make time to speak to my referring doctors because I love the community, and because these cases also have to come back to y'all once they are, once they need other things that aren't skin related. So those things I think are a few helpful tips from me.
Yeah, I like that. And, on your note of like just a sentence about like the bigger problem or whatever weird and why they sent it, I think about like just a traditional referral document. Some people have like just a document that they put out at the specialty hospital. I honestly don't think we have an official one at Iowa State for internal medicine, at least. But something that you can send to the RDVM just saying like, what is the problem? Like, what have you done so far? And like a nutshell. It doesn't need to be anything super long. Like, I agree. I need, I'd say I need records to make the most informed decisions about how to proceed in a patient's care that's referred to us. Because oftentimes the last thing that I want to do is repeat any diagnostics that maybe have already been completed that are irrelevant to reassess at that point. A small example would be like a 40X tick, like a heartworm test. Like I don't need to repeat that if that's been done like 5 days ago or something. But at the same time, there's like blood work that was done from years ago that might not seem very relevant. But for me and a cat or a dog with like kidney disease, like maybe that data would be very helpful in saying, okay, that dog or cat's kidney values were normal back then. And that would be important to the case. So, as a specialist or in training, I should say, I have gotten those sets of records that are like hundreds of, I think the highest I've ever seen was like 200-page records. But
Wow.
But mine are often anywhere from like 10 to 25 pages long, depending on how long things have been going on. I have some that are like 5 to 10, but most of them are relatively long. But I like Jeff said, I look through those. I pull the important data from them. I have learned to double check some of those things with the client, just to make sure that timeline fits and everything that they've done so far is understanding. Just as an example, I had a client that came in. I won't say any names, but basically the cat kept having respiratory infections, and I was like, "Oh, well, I saw your cat had an FIV test done 3 or 4 years ago, and it was positive, and maybe that's part of why this cat's not this is an immune disease or a viral disease for non-veterinary listeners that can really harm the immune system." But anyway, it was probably part of the underlying problem, and the clients had no idea that had been done years ago and that their cat had that virus. So it's just really important for me to have that information.
Can I make another point there too, Brandon?
Yeah.
Not to belabor the point on records, but one thing that I found with a couple, every now and then, you'll get clients that are like, and I'm sure we've all experienced it at one point or another, is like you ask them a question and they're like, well, that should be in the records. And then you go back to your records and you're like, I don't see that in the records. Like if I have nothing, then I'm like, and it's like the first time I'm seeing that client, I'm like, well, I don't have that. Your vet didn't send it, or maybe it got lost in translation. And I generally try to give I'm always trying to be respectful and tactful to my colleagues. So in general, I'm never gonna bash another doctor in the room, I'm always trying to say, like, I'm always looking at things from a team standpoint, and I think of referring doctors as a part of the team, and I'm a part of their team, and the client and the pets are a part of the team. But it's super helpful when, let's say, if like something more advanced has been done, like if a biopsy has been done, and I can look back at those records and say, oh, this is what's been done. Here are my next steps, and they make more sense. I can start you on this on cyclosporin. I can start you on high doses of steroids, or even if blood work has been done, sometimes owners just don't know the nitty gritty details of everything that's done, and I don't expect them to. But sometimes I will want to start immunosuppressive doses of steroids, and I really need some blood work, and they'll be certain that some has been done, and it's just like a 40x, and they don't know the difference between a 40x drop of blood and a CBC chem, and I don't expect them to, but I have had owners on one side get very upset when I don't have those records, and on the other side, when I do have them, they love it when I can come in and say, hey, your vet did a great job. I see the CBC chem here. Your regular internal organs and everything look pretty good. I don't need to rerun any additional testing, so we can move forward with XYZ. And they really, really like that. And it really helps me be an advocate for those doctors who are referring as part of making us sound like a team.
Yeah, I 100% agree. Even on that note, like I have a couple, I should say, I have a lot of clients that their GP is like their person for their pet. Like they've been going there for anywhere from 5 to 10 years. A lot of the patients I see are older. So they're like, yeah, we've been with Dr. So-and-so for 10 years. He's taken really good care of my pets. And it's great. Like when I have the records and like I can see all that stuff and I'm like, yeah, they did XYZ. And like clients can get like frustrated really quickly when they're like, oh, like so-and-so didn't send us his records, or, this thing wasn't done 2 years ago or whatever. So yeah, it can be tricky when you're the new guy or gal, depending on your situation, calling or seeing a patient for the first time, and the patient's been seen by another GP for years, and now you're the kind of the bad guy until things get sorted or you get those records or whatever. And yeah, medications are huge. So records. I'd say if there's one thing that I need, it's all of the records whenever I see a patient. There's, I'm sure we could talk about this longer. I don't know if there's anything else that you guys thought of or wanted to add to the conversation, maybe that we hadn't brought up yet.
This is Jeff. The only thing that I was gonna mention, which I think is helpful for people out there, if you don't live near a specialist, there's a couple of things you can do. Like you can use Venn. You can look at those dusty old books that we probably haven't opened in a while that the clinic has. Open them up. Call a specialist. If there is one that's not in your area, but the closest one that you have, and just get their opinion. I really appreciate it. I'm sure, Brandon, you can relate when someone says, hey, this client can't refer for money reasons, or they're too far, but what can you help me out with, or what advice would you have for XYZ situation? Like I really like helping those cases. And then just the other thing would be, like, if you are interested in a specialty, even if you don't want to specialize, don't be afraid to focus your CEs on that. You don't necessarily have to be a specialist to be really good at something that you're interested in. And sometimes you can build your niche in your clinic, kind of like Adam when he mentioned that there's some GPs who are not specialists but do certain surgeries and can get them in that specialists can't. It really depends on your comfort level and what you like to do, but you could go to CEs, conferences, and spend a lot of time on something you're very interested in, even if you're not able to do a residency. So I still think there's a lot of stock in that, especially if you're nowhere near a specialist.
Yeah, I agree. There's a lot of resources to kind of make yourself as much of a Swiss Army knife as possible when you get a client or have to see a patient that is just unable to refer for a variety of reasons. I think that at the end of the day, I would rather a GP in the area reach out to me and like answer a question about a potential referral, rather than maybe them not reaching out and do the best that they can in the circumstances. And then maybe the client finally has the ability to refer, and there's some things that I would have recommended differently along the way. I always want to, be as welcoming as possible, because at the end of the day, I just want to do what's best for the patient. And if I don't need to be directly involved, then that's fine. Well, it just kind of as a quick outro, I don't know if you guys would like, after kind of talking about this together, or just like now that we thought about it for the past 30 minutes, is there anything that you might do differently or change in the future when you're in a situation where you have to refer? Or on the flip side for specialty, is there anything that you would kind of do differently when you have a patient coming in from a GP on a referral?
This is Adam, and something that Jeff said earlier in the episode kind of stuck out to me, where he was saying that when these clients come to see a specialist, they are kind of looking to them to kind of be the savior, essentially, and fix all the problems and make everything better. So one thing that I feel like I could do as a GP would be setting some realistic expectations for the owner before they go see the specialist, and just try to let them know, like, hey, this is our next step, so we can evaluate what's going on further, and maybe discuss some other treatment options. But this may not necessarily get us back to perfect. So I thought that was a good point to bring up, that, again, that is kind of a lot of pressure on you guys. Those people come to you and expect you to kind of fix it all, when they go to that next tier, that next step. So trying to set that expectation of, this is just our next step to try and figure out what's going on and maybe make things better. But, we're going to do what we can and whatnot, but just setting those expectations.
And this is Chris. I mean, I agree with that. Definitely setting the expectations and kind of being realistic with the goals. Like, if you're sending a dog with cancer, like, the specialist isn't going to maybe cure them, or like, there's no guarantee. Like, that's the next step to figure out what's going on next. So then we can kind of figure out a game plan to pivot if we need to. Another thing JT said earlier too was the records of, like, going back with clients, and we'll get kind of second opinions. So, like, we're almost a referral, or like they just picked us out of the blue as GP. Like, I'm going to go to this guy to fix it. And I look at it and I'm like, you should go see a specialist, but they can't for whatever reason. Or they kind of get upset with their previous vet. And again, like JT alluded to, like, you don't want to put anyone down, but I'm like, sometimes they send us stuff and they're like, oh, well, why did you figure it out after this test? I'm like, well, I kind of had the benefit of the doubt because they already did all 4 of these tests and we didn't get the answer. And now I do this one other test, and that was probably their next step, but we left too soon, type of thing. So I've been in that situation before multiple times, and it's been like, we're not the good, like, we weren't just more brilliant. And we just got lucky because we were able to continue and see what the next case was, type of thing. So essentially is what I'm saying is, like, I know JT's like, don't bash, like, we don't want to bash our clients. We want to work as a team. And I definitely feel that case too with you guys, as well as, like, working as a team with the GP or with the referral specialist that we refer to, but also of things I would do differently. There's not a whole lot I would do differently because you two kind of have ingrained into me already to kind of send the records, be detailed with everything and do everything. So I think for the most part, like, I'm good. I just send them all the stuff and, okay, here's my records. I did this already. I did that. I already gave them the estimate for it's going to be around X dollars. Like, go. Like, we already talked about everything. So, but you guys have, I mean, it's just, I talk to you guys all the time. So I already know what the expectations is, tell those people now because you guys have talked about it.
And this is Jeff, and I'll say, I also don't think I'm going to necessarily do anything differently, but only from a standpoint of, I think all of these are good reminders, and I feel very comfortable with the fact that sometimes I still have to refer things, and I like to keep myself in a humble spot. And I appreciate what you said, Chris, because sometimes when you're the second opinion doctor, exactly what you described is exactly what happens in specialty land. It's crazy how people will feel like I'm sort of a hero because of XYZ, but I'm like, I'm always candid in the exam room, and I'm like, well, your vet did plans A, B, C, and D. They did the skin scrape, the cytology, the culture. The next thing to do was to biopsy, and that's how I diagnosed pemphigus or whatever the case may be. So it really is a team, and sometimes they will still kind of put you on a little bit of a pedestal, but I'm always trying to make sure we understand the full relationship in the team, and that it was more than just me, but they made my job a lot easier. So sometimes they come in and I'm like, this is the only next step to do. Let's do it. And it helps me to be quite decisive.
Yeah, I appreciate what you said, Adam, especially in the internal medicine service. We're the people that find the problems most times, or often, like, not even most times, I'd say, like, sometimes we'll rule out all the other things that it's not and still not find the primary problem. But it's not always a fixable one. And I'm referral central too. I refer if I find cancer. I'm referring to oncology. If I find something that needs surgery, I'm referring to surgery. If I've referred to dermatology multiple times during my residency. So I think at the end of the day, we're just trying to be as efficient of a team as possible between GPs and specialists, and we just want to do what's best for your pet. So with that, thank you so much for listening to the Dogtbros. If you enjoyed it, please leave us a 5-star review on Apple Podcasts or anywhere you listen to podcasts. At least Jeff and I will love you forever, but we'll love you forever.
We will. We all will. I swear.
It would also be helpful for us if you could share the episode with others or anyone who may be interested in today's topic. You can also tell us what you want to hear. You can drop suggestions in the comments or shoot us an email at thedogtbros@gmail.com or DM us at thedogtbros on Instagram. You can also reach me on Instagram at drmasonim.
And this is Adam. You can reach me on Instagram at DrAdamDVM. That's DrAdamDVM.
And this is Jeff. You can catch me on Instagram or TikTok at DermDrJeff, DermDogtorJeff.
And this is Chris. You can reach me on Instagram at dr.chrishernandez.